I would like to introduce Charles King. And Charles has about 20, 25 minutes more that he can be with us. So after his talk, we will do Q&A with Charles. Charles King is co-founder and the longtime CEO of Housing Works, Inc., a community-based not-for-profit organization that provides a full range of services, including housing, healthcare, mental health, chemical dependency services, legal advocacy, and job training and employment for homeless men, women, and children living with HIV/AIDS and other chronic conditions. Charles served on the governing body of UNAIDS as a member of the to the PCB, I believe that's the Program Coordinating Board, and was co-chair of the New York State End of AIDS Task Force. He is currently the co-chair of the Ending the Epidemic Subcommittee of the New York State AIDS Advisory Council. He also co-chairs Act Now and AIDS, a national coalition towards ending the epidemic, and co-chairs the Visioning Committee of the National AIDS Housing Coalition. Charles holds both a law degree and a master's degree from Yale University and is an ordained Baptist minister. Charles, thank you for joining us.
Thank you, David, for inviting me. I've been asked to give an overview of the good, bad, and ugly for people who use drugs in New York City and New York State during the COVID pandemic. Just to set the stage, New York was the first metropolitan area in the United States to have a major surge of COVID. We were getting diagnoses well over 1,000 a day. Ultimately, over 20,000 people died. Our hospitals were overwhelmed. In New York City and much of the state, we went into a complete shutdown beginning the last, or the American version of a complete shutdown, I should say, beginning the last week in March, and that continued in New York City through May. And we have slowly been opening up the city, going at a far slower pace than many of the other states in the United States and metropolitan areas. So first, let me tell you what we don't know, and that is we don't know the data on drug overdoses during the surge, the pandemic. Data just isn't available. We still don't have data on overdose in New York City and New York State for 2019, much less the last 3 months. So it will probably be a year or more before we're able to really deeply analyze what has taken place. What we do know is that overdoses anecdotally are spiking at huge rates outside of New York City. Spiking not as high, but still spiking within the city over the last 3 months. Even then, we're not sure that when we get the data, we'll get the full measure of overdose deaths because they might well have been misclassified. If the decedent's death was recorded as COVID, this is particularly possible in cases where persons died in their homes alone. Our medical examiner's office during the peak, April and May, was not able to properly track, much less conduct autopsies on deaths during this time. What we do know factually is that coordination of an emergency response for people using drugs has been sorely lacking. We also know that emergency room visits for overdose in New York City went down dramatically during the second half of March and April, but by May had gone back up to normal levels. Possible reasons may include a lack of transportation. Ambulances simply were not available for hours on end during the peak of the surge, and emergency rooms were turning patients away before they even showed up at the door. And so we don't know exactly how this impacted, but we know that there was a tremendous decrease in people showing up at ERs in the midst of overdose. In the rest of the state, even though emergency room visits for non-COVID related events went down dramatically, the percentage of people showing up for overdose in emergency rooms actually increased proportionately. So that is a major indicator of the rest of state surge. Just to talk a little bit about some of the dynamics that took place in New York City, at least one major syringe exchange and naloxone distribution program in Upper Manhattan and the Bronx closed for over a month, leaving severe shortages in those parts of the city of both naloxone and syringes. Anecdotally, people who were enrolled in that program, instead of finding other programs outside of their neighborhood, ended up sharing syringes during the period that the program was closed. We also know that methadone clinic attendance declined precipitously as people on methadone feared going to their programs, worried about contracting COVID. There was an uptake in 7-day and 14-day distribution of methadone, though some programs were reluctant to increase take-home amounts despite the relaxation of restrictions on the federal level. Our New York City Department of Health started a home methadone delivery program, but even today it is grossly underutilized because many of the methadone programs are reluctant to trust their participants. That's both trusting them around diversion and trusting them if they get multiple doses not to overdose. So anecdotally, many methadone users have returned to other substances. Also, anecdotally, people in abstinence have relapsed at high levels due to social isolation, and this seems to account for many of the upstate overdoses that we've seen. One of the things that happened during the surge is that drug supply became highly unstable. Partly this was due to the difficulty of moving drugs when so many things were shut down, and also due to sellers becoming ill due to COVID. People who use drugs also suffered intermittent withdrawal due to lack of cash. As the city shut down, there were reduced opportunities for panhandling and other forms of income generation that people who use drugs in New York would frequently fall back on. Anecdotally, heroin without fentanyl actually became more common in New York City, leading to a greater use of stimulants with fentanyl. Still, there is a prevalence of heroin with high fentanyl levels in this very unstable and inconsistent drug supply. In both New York and Buffalo, anecdotally, nearly half of the overdoses have been due to fentanyl mixed with cocaine. And in May, in the state's capital region, in 24 hours, in a small town outside of Albany, there were 30 overdoses with 4 deaths due to crack with fentanyl. Methamphetamine use has been exacerbated as well upstate, often due to the lack of supply of other drugs. And there has been a dramatic increase in sharing syringes, particularly in rural regions of the state, which already have very high prevalence of hepatitis C. One bright spot has been that buprenorphine initiation through telehealth was a major breakthrough. And in addition to that, what we saw was various areas of the state, including Plattsburgh, for the first time developing strong buprenorphine programs. Anecdotally, we also can report a much better show rate for people on buprenorphine because of telehealth. So this is a major advance that we hope to hang on to afterwards. Always not right on the bupe front. So for example, in Buffalo, a number of people were arrested for bupe possession. Two other areas that I would like to cover briefly, trying to stay within my time limit, are incarceration and homelessness. While our City Department of Corrections has not issued reliable data, what we do know is that there have been a much higher rate of COVID infection and a higher rate of death on our city, our largest city prison on Rikers Island, and other local jails around the state than in the general population. This is really important given the high percentage of people incarcerated for drug-related offenses or for petty crimes associated with drug use. Here in New York City, a number of older and chronically ill inmates have been moved out of Rikers Island into hotels, but infection rates on the island remain very high, and access to PPE, including masks and gloves, is prohibited in all of the state's jail settings, leaving people very much exposed and unprotected. And at least one major county jail stopped doing buprenorphine induction during the COVID crisis, a serious setback as we've been trying to expand this. For homeless people, there have been a number of issues. Initially, our department, first of all, I should say New York City runs the largest homeless shelter program in the world, I believe, and that's because under our state constitution, people have a right to shelter. So on any given night, we have 70 to 80,000 people in shelter. Of these, about 13 to 15,000 are single adults. Generally, these are mass warehouses where people are living in a dozen to 1,000 people in a single room. Obviously, not the best place to shelter in place from something transmissible as COVID. The initial policies in the shelter system, particularly in the single shelter system, was that if somebody was suspected or tested positive for COVID, they were to be discharged from the shelter with no place to go and not allowed to return until they had a COVID negative test. With some powerful advocacy, we were able to stand up 5, and now there are 4 isolation shelters for homeless people who are positive for COVID or have COVID symptoms. And Housing Works operates one of them and is providing all of medical and behavioral health services in all of the others. In addition, we had a major crisis for people who are homeless living on the streets. Many of them refused to go into the shelter system. They were wary of the shelter system in advance, but were even more wary of the shelter system in light of the possibility of contracting COVID. And by the way, even now, when New York City testing is showing only a 1% positivity rate, in the shelter system, testing is showing a 7% positivity rate. So their fears were well-founded. This became a crisis when the city and state decided to close our subways from 1 o'clock in the morning to 5 o'clock in the morning and tried to round up homeless people who were living on the subways and coerce them into the shelters. Again, due to advocacy, the city is now standing up stabilization shelters in hotels, allowing operators to provide homeless people from the streets with a private room. And due to some incredible advocacy, we've had a major breakthrough in that our Department of Homeless Services is now requiring that these stabilization shelters operate on harm reduction policy. Contrary to that, in our test and trace program operated by the New York City Health and Hospitals Corporation, their isolation and quarantine shelters search people, and possession of drugs or alcohol is grounds for immediate discharge, even if you are contagious with COVID. Similarly, leaving an isolation hotel for anything other than a medical appointment is grounds for discharge. And of course, many people who are using drugs, who are dependent on drugs or alcohol, who can't bring it on site with them, would leave to procure, and thus we're putting people who have the possibility of transmitting the virus out on the street. Fortunately, I guess on that last front, very few people have been willing to go into these isolation shelters because of these rules, but still a lot of work to be done. I think I went over my time, so I will stop there.
Thank you, Charles. So I will start with one question in the chat from Charlie Sullivan, the Citizens United for the Rehabilitation of Errants. But also, in case you didn't see it on the chat, I'll mention if you'd like to ask Charles a question or make a comment, request you go to use the raise hand function in the participant screen, and then I can call on people in turn. If for some reason you're not able to find that or it doesn't work, then people go ahead and unmute yourselves to speak. So the question from Charlie is, would supervised injection sites have reduced these overdoses?
That's a softball, no doubt about it. Certainly what we saw at the syringe exchange programs that remained open around the state was no reduction whatsoever in utilization of the syringe exchange services. And I want to compliment both the city and state departments of health with ensuring that these programs could remain open and do so safely. However, people were still having to go out and procure in a very unstable situation where they didn't know what they were purchasing. And so undoubtedly being able to inject or use where you're being monitored would have gone a long way to mitigate against overdoses. I would also point out that because of the shutdown and isolation orders, many more people were injecting alone by themselves, which of course is contrary to best practice to reduce the possibility of an overdose death.
I'll ask a follow-up to that. Just what is the status of supervised injection site efforts in New York?
So we had been very optimistic 2 years ago that we were going to get a research pilot authorized. We had the sign-on of the state health commissioner, who is the person who has the legal authority to authorize this. We had funding lined up. We had the support of New York City Mayor, the New York City Council, and the Ithaca Mayor. Unfortunately, after the U.S. Attorney intervened in the Philadelphia case, our governor got cold feet, and we've seen zero momentum on that. We had hoped that a new all-Democratic Senate would pick up the issue. They didn't do a study, but ended up not advancing a bill last year. We're going to take another run at the legislature this year.
Okay, thanks. So Scott Cecil. Scott, you're next.
Yeah, thank you, Dave. Thanks so much for the presentation, Mr. King. I wanted to ask about the isolation shelters for people who are experiencing homelessness. So you mentioned, of course, the problem is that folks were being kicked out of the other shelters that were available. I'm wondering how testing fits in, because something stood out in there for me in what you said, which was that folks who either have COVID-19 or have symptoms could go to the isolation shelter. So how did testing fit into that, if at all? Because someone could be sick with another illness, right, and simply have COVID symptoms and then go to the COVID shelter and contract it. Were you able to include testing either at the original shelters that were kicking people out or at the isolation shelters, or both, or neither?
So just remember, or you may not be aware of this, but beginning the third week in March, due to the shortage of testing, New York City stopped offering testing to anyone who was not being admitted to the hospital. Therefore, we couldn't test. We could only go on symptoms unless somebody went to the emergency room. We did receive in the isolation shelters a number of people who were being discharged from the hospital. but we also took people in who were simply showing symptoms in the shelter system. And without testing them. And we were initially keeping people 7 days, then that increased to 14 days. It has since gone up to 17 days. Now we have the ability to test, and DHS has contracted with an entity to test all of their shelter residents. So we are able to do that. But the other thing I can tell you is we were seeing a lot of people coming in with very serious comorbid conditions. Fortunately, Housing Works had insisted on a rich medical staff for ours. And so we've been able to treat those other conditions, including diabetes, hypertension, OCPD. And it's actually because of that that we were asked to provide the medical care in the other 3 COVID isolation shelters, which we will continue to do. What we're seeing coming in now is largely people who are testing positive but are asymptomatic.
Okay, Ninan, you had your hand up.
Yeah, David, and thanks, Charles. I was waiting if there was somebody else who wanted to ask a question, but Charles, just on the you mentioned the harm reduction and methadone users and the provision of methadone to the doorsteps of people, and just correct me if I'm wrong. So we are looking, I mean, COVID has given us the opportunity to do a lot of innovative stuff. So, and as in HIV, we are trying to do multi-month dispensing. So is this something that you think will come out of this, the way that we're functioning during the COVID, that we'll be able to give multi-day doses as a policy shift across the programs in New York State and maybe other states as well? Thanks.
I am more comfortable with saying that we will be able to hold on to our advances with buprenorphine. Then I would say that we will be able to hold on to our advances with methadone. And I think the problem there is that buprenorphine prescribers are far more willing to experiment. They're also far more willing to trust the people who they're prescribing for. I think in the methadone clinics, it's an old model. There's a lot of very traditional operators, and the presumption there is that you don't trust the people you're prescribing to, both for purposes of diversion as well as to avoid overdose. So while we have seen a fair amount of 7 and 14-day visits, many of the programs are still insisting at the end of 7 or 14 days that people come in for toxicology, which sort of defeats the purpose of home delivery, though they are getting extended supply. But then all too many people, programs are still adamant, especially new initiates, that they have to come in every single day. And that has been an uphill battle to persuade programs to trust the people who are there. They're there because they want treatment. Can we show a little bit of faith? But I'm not as optimistic with methadone as I am about buprenorphine.
Ninan, you may as well have left your microphone on because you are next. Well, first, sorry, any further questions for Charles or comments? Okay, well, Charles, thank you for taking time on sounds like a busy day full of errands to join us here.
Thank you. It's good to see you all, and I apologize for needing to leave early. Take care.
Actually, if you're still there, we just had a question come in on the chat. Well, I'm sorry, Charles. Charles did sign off. So Ricky, I will be sure that Charles gets that question, and we'll send you the answer. If anyone else happens to know, Ricky Avancenia of the Ecological Society of the Philippines has asked, did the 78,000 nightly who are in shelters in New York increase or decrease during the lockdown?